Now, the incidence of diabetes as such in the general population has increased a lot. Uh, why now the incidence is about 9% in pregnancy? The incidence is about 9%. You can imagine how high the incidence is. Now, why this change has occurred when you compare it with the previous times is because of the change in the lifestyle. Generally, the incidence of diabetes has increased. So, number of women becoming pregnant who are diabetic is also increasing. Change in lifestyle then causing obesity, weight gain, increased BMI, then presence of metabolic syndrome, and then the incidence of PCOS also has increased. All these are precursors. They all are, I would not say etiology, but risk factors for the development of diabetes. So, because of this, the general incidence has increased. Now, basically, how do we divide this diabetes uh, as a pre-gestational and gestational? See, previously, diabetes was called gestational diabetes, insulin dependent type 1 diabetes, and non insulin dependent diabetes. Now, the classification that we consider is two classes, pre-gestational and gestational. Pre-gestational means before pregnancy. The patient was diabetic before pregnancy. That means it is uh, a pregnant woman becoming, a diabetic woman becoming pregnant. Now, the second group is the gestational diabetes, where after becoming pregnant, the patient developed diabetes. So, how do we define this gestational diabetes? It is the carbohydrate intolerance or hyperglycemia that you see that is detected for the first time in pregnancy. Patient has come to you and you have detected that she is diabetic. Then we call it a gestational diabetes mellitus. Now, pre-gestational diabetes is divided into two groups, type A and type 1 and type 2. Now, previously, this type 1 was called juvenile diabetes. This is all in medicine, general medicine, you must have studied. Type 1 was called juvenile diabetes, and the type 2 was maturity onset diabetes, it was called. Now, instead of those terms, we call it a type 1 and type 2. See, the difference between these types is type 1 occurs in younger patient is not obese, hyperglycemia is there, and then they are more prone for ketoacidosis and more complications. This patient is dependent on insulin. Cannot be this because the hyperglycemia cannot be controlled by oral hypoglycemic agents. Patient has to be given insulin, and very high blood sugars and very low blood sugars, hyperglycemia and hypoglycemia episodes are very common in these patients, and control of diabetes is more complex and more difficult in type 1 diabetes. In type 2 diabetes is where the patient is older patient, obese patient, the hyperglycemia and hypoglycemia episodes are less, complications are also less, and a patient can be treated with oral hypoglycemic agents. So that is the basic difference in the type 1 and type 2 in the pre-gestational diabetes. Now, gestational diabetes is where the hyperglycemia you have detected for the first time in pregnancy. Basically, the features of the gestational diabetes resemble more a type 2 diabetes mellitus. Okay, so then incidence is about 9%. Gestational diabetes incidence has increased over recent times. It is as high as 10 to 12% now. Now, this classification was previously followed by, as given by the ACOG, American College of Obstetricians and Gynecologists, but now we have given up. The classification that before is already what I have described. Just for completion's sake, I will tell you, I don't know if they are teaching you this still in the general medicine. This is a Priscilla White's classification, uh, uh, particularly of the pre-gestational diabetes, where it is dependent upon the age of onset, age of the patient when diabetes appeared, and the duration of the disease, any vascular disease is present or not, and the treatment, type of treatment. So depending upon that, It has been divided into A, B, C, D, F, R, and H. And the duration of pregnancy and the presence of complications like retinopathy, benign and proliferative, or a nephropathy where kidneys involved, or heart disease is there. So all this makes a difference in this classification. This we are not following now, just for completion's sake, I'm telling you. Now, and see, this class A1, A2, another way to classify was depending upon the fasting and postprandial plasma glucose. Again, we are not following this. Right. Now, to know about this diabetes, the uh, details, the complexity of the diabetes, to understand that, you have to know what happens to the carbohydrate metabolism in pregnancy. See, in pregnancy, lot of changes are come, a lot of hormones are being produced. Initially by the corpus luteum, and then later by the placenta, and also by the adrenal gland in the mother. So by all these hormones like estrogen, progesterone, HPL, that is human placental lactogen, cortisol, then some interleukins and things like that, which cause a change in the blood glucose. They cause multiple changes in the carbohydrate metabolism and cause hyperglycemia. So, what happens in pregnancy? What I'm talking is about normal pregnancy. So, in normal pregnancy, in the early pregnancy, there is increased estrogen progesterone production by the corpus luteum. So, these hormones stimulate the pancreatic beta cells to produce more insulin. So more insulin is produced. And what is the action of insulin? Basically, it uh, uh, it reduces the glucose level in the blood. Now, how does it do this? Either by removing the glucose for storage, or removing the glucose for utilization by the peripheral cells. At the peripheral cell level, utilization is increased, or it is stored. It is taken away from the blood and stored. This is the basic thing that the insulin will do. So, because of the stimulation of the pancreatic cells and more insulin production, what is happening in earlier weeks is there is increased glycogenesis. That means formation of glycogen in the liver and other organs. Reduced glycogenolysis. Glycogenolysis is where glycogen is converted into glucose and released into the blood. That is reduced. And there is increased peripheral utilization of glucose. So the overall effect is there is reduced maternal blood glucose. So, and added to this is the mother having vomitings, nausea, hyperemesis, etc. She doesn't take proper nutrition. So all this adds together, and mother's blood glucose may become less also. So what we call a state of accelerated starvation is there in the initial months. Okay, so then in the later months, what happens? More hormones are being produced. See, placenta takes over function after the 12 weeks. So the placenta is now producing more and more hormones in addition to estrogen and progesterone. Hormones like HPL, that is human placental lactogen, and cortisol are produced by the placenta. Now, what do these hormones do? They cause increased insulin resistance. Like in a diabetes patient, the insulin resistance is increased. That means at the peripheral cellular level, the entry of glucose into the peripheral cells and utilization is reduced. So the effect of this is blood glucose is rising, right? So there is hyperglycemia, and at the same time, glycogenolysis is prevented. No, sorry, glycogenolysis is encouraged. So there is more glycogen is being reduced to glucose, and again the blood glucose is increasing. So there is increased insulin resistance, more glycogenolysis, and so blood glucose is increased. So now, if the mother cannot utilize glucose for energy production in the cells, then what does she use? She uses the fats. So fats are used, and so there is lipolysis. All the fats are lysed, and triglycerides and free fatty acids are released into the blood. So there is increased triglycerides, fatty acids, hyperglycemia, increased lipolysis, This is all the effect that you see in the later weeks of pregnancy, which is actually similar to a diabetogenic state. So we call the pregnancy a diabetogenic state in the later weeks of pregnancy. So in the earlier weeks, we call it a state of accelerated starvation. In later weeks, it becomes a diabetogenic condition. Okay, so this is what happens in normal pregnancy. Now, so when a woman becomes uh, pregnant, a diabetic woman becomes pregnant, or a pregnant woman develops diabetes. See, when you detect the diabetes in the first trimester of pregnancy, mostly we assume that it could be a pre-gestational diabetes because, as I told you, in the first trimester, in a normal pregnancy, there is less blood sugar. So, if the blood sugar is more at this time and hyperglycemia is there and you detected diabetes, then probably she was pre-gestational diabetes. That means a diabetic woman has become pregnant. So, if after in the second trimester you detect the diabetes, then it could be a gestational diabetes. Okay. So the time when you detect also becomes important. Now, uh, when the diabetes and pregnancy, what is the effect of diabetes on pregnancy? What happens to a pregnant woman when she becomes diabetic? So there is increased abortions are increased, spontaneous abortions are increased, more infections are there, particularly urinary tract infection and vaginal candidiasis. Very typically, if you detect any these two conditions, a recurrent urinary tract infection or a vaginal candidiasis in a pregnant woman, you must investigate this patient for evidence of any diabetes. Okay, then incidence of preeclampsia and the pregnancy-induced hypertension, that is preeclampsia, is increased. There is polyhydramnios. Why polyhydramnios occurs? How does polyhydramnios means? Increased amniotic fluid in the amniotic cavity. Now, what is the source for this amniotic fluid? It is a fetal urine uh, that is responsible for the amniotic fluid, isn't it? And little comes from the exudation from the placental surface, etc. Most of it is from the fetal kidney. So when more hyperglycemia is there and glycosuria occurs, that is increased glucose in the urine in the fetus also. So there is more urination, see more urine formation, and so more amniotic fluid will collect. So this leads to polyhydramnios. So now you understand why polyhydramnios occurs. Okay. Then because of the complications, there is increased rate of cesarean sections and all the morbidity associated with it. There may be a prolonged labor. Prolonged labor may be because of a large baby. Then shoulder dystocia is there. Shoulder dystocia, what is the meaning of dystocia? Is any obstruction. Shoulder means when the shoulder is being delivered, when the shoulder of the fetus is being delivered, there is obstruction. That we call as shoulder dystocia. Here, what happens is the head is delivered, but then the shoulders get stuck because the bisacromial diameter is more. The shoulders are quite wide in this fetus. Now, why this occurs is because of the increased weight of the fetus. See, what happens in diabetic patients are known to have overweight babies. Okay, when the large babies are there, why this large baby size is large? Because of the deposition of fat, particular, and also the increased size of the muscles. So, all this fat is mostly deposited in the chest and the abdomen. So the shoulders are wider and the bisacromial diameter is more. So head may be delivered, but because of the large bisacromial diameter, there is difficulty in delivery of the shoulders, what we call a shoulder dystocia. Then there are genital tract injuries due to operated deliveries. We may give an episiotomy, and because there is difficulty in delivery of the shoulders, there may be extension of the episiotomy, or there may be cervical tears, or she may go into prolonged labor and then rupture of the uterus can occur. So any type of genital tract injuries are possibility. Then increased postpartum hemorrhage. Postpartum hemorrhage is increased because of various factors like prolonged labor, then over distension of the uterus, so hypotonic postpartum hemorrhage, or because of the injuries, there may be traumatic postpartum hemorrhage. So overall, increased postpartum hemorrhage. Then chorioamnionitis and postpartum endometritis. So you all know a diabetic patient is more prone for infection because glucose is a very good source for the growth of the organisms. So chorioamnionitis, that is infection of the chorion and amnion, and then after delivery in the postpartum period, endometritis may be there. Then again, and also lactation failure, inadequate lactation, and so the baby may not get adequate feeding. So all these are the maternal effects. Now, what happens to the fetus? In the fetus, there may be congenital malformations. See, normal incidence of congenital malformations is up to 3%, but here the incidence may be up to 10%. And this is particularly more if patient is a pre-gestational diabetes patient. Now, because a pre-gestational diabetes means the patient was already having hyperglycemia and she became pregnant. So in the first trimester, there is hyperglycemia. It has been seen that this exposure of the growing embryo to this hyperglycemic environment is what is predisposing for the development of malformations. You all know the organogenesis occurs in the first 3 months of pregnancy. In the from the second trimester, whatever the organs are formed, they are growing in size. So this is at the period of this organogenesis, the presence of hyperglycemia causes increased malformations. Now these malformations, neural tube defects like anencephaly, spina bifida, meningomyelocele, vertebral dysplasia may be there, or heart malformations like VSD, that is ventricular septal defect, coarctation of aorta may be there, or particularly one condition called caudal regression syndrome may be there, where the caudal portion of the fetus is not developed. So this it does not mean that there is more incidence of this regression syndrome, but if you find a case of caudal regression syndrome, then you have to think the mother may be having diabetes. Okay, then IUFD, that is intrauterine fetal death, is a possibility. What we have seen is sudden intrauterine fetal death has been seen in diabetic mothers. We are all, as obstetricians, we are all very scared that one day when we come for rounds, we will see that the fetal heart is absent. Okay, that is a nightmare for the patient and for the consultant also. So this incidence may be as high as 10 to 30%, particularly if it is uncontrolled diabetes. So good diabetic control, euglycemia, is extremely important in diabetic patient. Now, why this occurs exactly we don't know, but it may be chronic fetal hypoxia and fetal hyperglycemia. These two may be responsible, but we do not exactly pinpoint why it occurs. Yes. Then fetal macrosomia is a possibility. This is very common. We call it a macrosomia when the birth weight of the fetus is more than 3.5 kg. For our Indian population, we take it as 3.5 kg, that is 3,500 to 4,000 grams, right? Or the weight is more than 90th percentile of expected weight for that period of gestation. Okay. Now, Peterson has put forward a hypothesis why macrosomia occurs in the fetus. See, maternal hyperglycemia is there. So all this glucose is going through the placenta into the fetus, causing fetal hyperglycemia. Then, when the fetal hyperglycemia is there, naturally this stimulates the fetal pancreatic or fetal pancreas to produce more insulin. So this results in fetal hyperinsulinemia. Now, so more insulin, more glucose in the blood, more utilization of the glucose. So there is increased growth of the various tissues in the fetus. So when the increased growth is there, particularly fat deposition is there, muscle mass is increased, fetus becomes larger. And so you get big babies in diabetes. Looking at these big babies, you don't think, oh, they are very nice, chubby and healthy, but they are not healthy. Why? Because of the hyperglycemia. Not only hyperglycemia, see, in the neonate, in the immediate postpartum period and in the early neonatal period, this fetus can have lot of complications. Hypoglycemia will occur. See what happens in pregnancy during when as long as the fetus is inside the uterine cavity, it is getting glucose, more glucose from the mother. But after birth, mother is not because it is separated, the fetus is separated from the mother. Mother is not providing any more glucose, isn't it? So, but at the same time, fetal pancreatic gland islet cells are very active because they got used to producing more insulin when they were in the maternal uterus. So now, for some period of time, this excessive production of insulin will continue even after birth. So when the fetal pancreas is producing more insulin, and that will act on the glucose and cause hypoglycemia. At the same time, the mother is not giving any more glucose. So neonatal hypoglycemia is a big danger in babies with who are born to diabetic mothers. Then hypocalcemia can occur. Hyperbilirubinemia and polycythemia. See, more RBC production was there during pregnancy. Again, an effect of the insulin and hyperglycemia. So all these RBCs, polycythemia was there, and so more of them were destroyed, and so hyperbilirubinemia. All these become evident in the neonatal period. Respiratory distress syndrome. See, the babies of diabetic mothers do not have enough surfactant in the lungs. You know, after birth, the expansion of the lungs, that is, the alveoli expand, they get filled with air, and this is facilitated by the presence of the surfactant in the alveoli. Now, there's a deficiency of this surfactant in these babies with diabetic mothers, and so these babies RDS is a possibility. Right. Then injuries to the fetus, particularly if there is shoulder dystocia. Shoulder dystocia, there is no time to take the patient to the theater and do a cesarean section. You have to do various manipulations to see that the baby is out. If you don't deliver this baby within 5 to 10 minutes, lung expansion cannot occur. Chest expansion cannot occur. Though the head is outside, baby is able to breathe, but the expansion of the lungs cannot occur. So ultimately, severe asphyxia will occur in this baby, and we may lose the baby also. So, to deliver the baby fast, we do a lot of manipulations. So, because of that, some birth injuries can occur. Then, all the problems associated with the malformations can be present in the baby because there is more incidence of fetal malformations. So, all these problems you see in the fetus. So, you know now, so many complications can occur in the mother and in the neonate. So recognition of the diabetic mother is extremely important. Early recognition and early treatment and achieving a euglycemic state is very, very important both for the sake of the mother and for the sake of the fetus. So, what are all the risk factors where you think, okay, this patient may be a diabetic patient? See, she does not know she is diabetic. She does not give you any history that she is diabetic. A pregnant woman has come to you. Now, what are all the features in history or on examination which make you suspect that this patient could be diabetic? So, in other words, what are all the risk factors which may point towards the diabetes, and so you have to screen this patient. Now, so what are all these risk factors in history? What is the history? Genetic suspects may be there. That means there may be a family history of diabetes. Parents may be diabetic, siblings may be diabetic, some or second degree relatives may be diabetic. So, history of diabetes. Then, obstetric suspects. That is, previous obstetric. Suppose she is a multigravida. Okay, she has had 2 or 3 previous pregnancies. Then, what will be the history like? She has previous bad obstetric history, previous fetal losses may be there. Like, for example, previously she had a large baby, she had an unexplained stillbirth, she had abortions, or she had IUD. I told you, intrauterine fetal death, sudden fetal death can occur. So that history may be there. Or she may have previously given birth to babies with congenital malformations, or she had a difficult delivery and traumatic delivery of the previous baby with a neurological impairment for the baby, or recurrent abortions I've already told. Then presence of preeclampsia in this present pregnancy or previous history of preeclampsia also. Then history of gestational diabetes in previous pregnancy is one condition where you about which you have to be alert, because gestational diabetes can be repeated in successive pregnancies. See, she may have recovered after the she has delivered. In between, she may not have hyperglycemia, she may not have diabetes, but again she has become pregnant and she may develop diabetes again. So, history of previous gestational diabetes is important. Then, uh, now in on examination, you see that she has got recurrent infections, urinary tract infections, vaginal candidiasis. You have treated the urinary infection, again 1 or 2 months later, she comes back with again infection. So, recurrent infections should make you suspect. Yes, then she gives a history of chronic hypertension. Before becoming pregnant, also she was hypertensive. So you know many times, many patients, the diabetes and hypertension go together. Then, if the mother's age is more than 30 years, nowadays many women are becoming pregnant after 30 years. That has become very common. That seems to have become an average age now, 30 years. So, as the maternal age increases, she is more likely to develop diabetes, particularly a pre-gestational diabetes. As you know, the incidence of diabetes as such increases with increasing age of the patient. Right. Then, on clinical examination, what findings will make you suspect she may be diabetic? She is very obese. She's maybe it is more than 200 pounds, that is more than about 90 kg. Then, or more than 15% of the non-pregnant weight. That means she has put on weight very rapidly. Then she is hypertensive now, or she's got UTI and monilin infection, or she's got polyhydramnios, or she's got vasculopathy, like a benign retinopathy is there. You have done a fundal examination, you have found that retinopathy is there, or urine examination has shown glycosuria. So all this again on clinical examination findings will make you suspect. So these are all the risk factors for uh, patient to detect a patient who is diabetic. Now, so you want to screen a patient. Now, which patient are you going to screen? Now, we have got what we say is which patient means a universal screening or a selective screening. Now, universal screening is where all pregnant women are screened for the uh, to detect diabetes. That means by examining the blood sugar, we screen the patient, and all pregnant women. That is universal, irrespective of age or previous history or risk factors. We screen the patients. So, which some countries follow the universal screening, some countries follow the selective screening. Now, selective screening means a patient where risk factors are present. What risk factors? I have just enumerated all the risk factors in history and clinical examination. So, when you see a risk factor, okay, you investigate, you screen this patient. So, that is we call it a selective screening. Now, if the incidence of diabetes in a particular country is more, because of lifestyle changes or genetic factors or whatever, if the incidence of diabetes is more, then these countries are following universal screening. Some countries, they like Canada or some European countries where the incidence of diabetes is not that high, they follow the selective screening. But in our country, we are following the universal screening because because maybe because of the changing lifestyle, the incidence of diabetes has increased, and India is considered to be a very high risk for development of diabetes, both in males and females. Okay, so what we are doing is universal screening. Now, how do we screen these patients? Universal screening. Previously, we used to do a test called glucose challenge test. Glucose challenge test. Now, here, the patient, irrespective of whether she's fasting or she's not fasting, when she's come for the first visit itself, you can do this. 50 grams of glucose is given to the patient, mixed in some water, and she's asked to drink this, taking about 10 minutes for drinking, and then 1 hour later blood glucose is estimated. Now, if the blood glucose is more than 130 milligrams per 100 ml, in some places they take it as 140 milligrams per 100 ml, then she's likely to be a diabetic patient. So she has to be confirmed with a OGTT, that is oral glucose tolerance test. If so, if this glucose challenge test is positive, then we do a oral glucose tolerance test to confirm the diabetes. Now, if this is negative, then the patient is reassured and the test is repeated again at 32 weeks. Initially, the first test is done at around 24 to 28 weeks. Okay, this was the glucose challenge test. Now what we are following is we have changed it. It has been changed according to the DIPSI guidelines. DIPSI is the diabetes uh, in investigating diabetes in pregnancy uh, analysis. It has been by it's a group national at the national level. They are screening. What they are advising is again patient need not come fasting. This patient is given 75 grams of glucose instead of 50 grams. What we are giving is 75 grams of glucose to drink, and then 2 hours later the blood glucose is done. Not 1 hour, but 2 hours later. And after 2 hours, if the blood glucose is 140 milligrams per 100 ml or more than that, straight away we can assume that the patient is diabetic. There's no need to even to do any OGGT. You can consider this patient as diabetic and start treating her for diabetes. Okay, so that is the test. That is 75 grams of glucose we are giving. That is the challenge test or screening test that we are doing now according to the DIPSI guidelines. Okay, now other tests, other people also employ fasting and postprandial blood sugar. Fasting of normally should be less than 100. Actually, the ideal would be less than 92 milligrams. And PLBS, that is postprandial or post lunch blood sugar, should be less than 140 milligrams. Anything above this, you consider them to be diabetic. Now, basically, now what we are doing is 75 grams of glucose test. Okay, screening test. Now, uh, OGTT. What is OGTT? Is what we call oral glucose tolerance test. Even for this is done in the non-pregnant people also, in the general population also. The physicians they advises for confirmation of diabetes. Now here, patient has a normal carbohydrate or high carbohydrate diet. She eats normally for 3 days before the test is done. After overnight fasting, in the morning, fasting blood sugar is taken, and then the patient was given 100 grams of glucose, and then blood sugar was estimated at 1 2 3 intervals, and O11's criteria were followed till recently. Okay, this what this slide shows are the O11's criteria, but now in recent years this has been altered, this has been modified, and what we are doing now is instead of 100 grams of glucose, we are giving 75 grams of glucose. Okay. So now the OGDT is also done with 75 grams of glucose. Okay. Now, when after drinking the 75 grams of glucose, fasting is taken before the patient is given glucose, fasting blood sugar. And then after drinking the glucose 75 grams, blood is drawn at 1 hour and 2 hour intervals, and the sugar is estimated. Now, here the normal values what we take is fasting 92 milligrams per 100 ml. After 1 hour, we are taking 180 milligrams per hour, percent per 100 ml. Okay, then after 2 hours, we're taking 153 milligrams per 100 ml. So remember, according to the 75 grams OGTT, I'm sorry that slide is not there, but according to the 75 grams OGTT, the fasting level is 92 milligrams, 1 hour value is 180 milligrams, and the 2 hour value is 153 milligrams. If even one value is more than normal, we consider the patient to be diabetic patient and start treating her. Okay, so these two are the main tests that we are doing. One is a screening test, one is the OGTT for detection of diabetes. Now, so okay, you have detected that a patient has got diabetes. Now, what would you like to do for this patient? You have to investigate the patient, see that see if she has got any complications, and if there are any complications, you must treat the complications. See that the growth of the baby is normal, and main thing is you must see that there is no uh, overweight of the baby. Okay, um, uh, that euglycemia is maintained. So all this has to be uh, followed. So it is extremely important that this woman has to be counseled when she comes to initially and you detected diabetes. You must counsel the patient, telling her, yes, you must come for more visits to the obstetrician so that any changes or any development, any complications can be detected as early as possible and treated. So, uh, uh, this counseling is very important. The patient must understand the problems that are associated with diabetes, what she problems she can have, what problems her baby can have. So, and be uh, regular in her visits to the obstetricians. Okay, so what do you do? Uh, you screen the patient is okay. Now you have to investigate the patient. So what investigations you will do? Urine examination, not only the complete urine examination, you have to do the culture sensitivity also because you may be having an asymptomatic bacteriuria also. That means bacteria may be present in the urine high, but symptoms may not be there. Then you repeat it at 4 to 6 weeks intervals. Okay. Then fundoscopy must be done to see if any look for any retinopathy, vascular changes in the retina. First at the first visit, and if retinopathy is present, then if necessary, she can be treated with laser, or she have to follow up serially to see if any worsening of the condition is there. That means repeated fundoscopy will have to be done. Right. Renal function test every 4 weeks because kidney is likely to be involved in diabetes. See, one thing you must all remember is that, like hypertension, in diabetes, every organ in the body can be involved because basically diabetes affects the blood vessels also. So the function of various organs can be affected, heart, kidneys, etc. So you have to be uh, on the lookout for any problems in the various organs. Then ECG to know if any ischemic disease is there. Then glycosylated hemoglobin. This glycosylated hemoglobin plays a very important role in the management of diabetes, what we call HbA1c. Now, what is this glycosylated hemoglobin? It is hemoglobin to which a glucose is attached. Okay. See, it in in a diabetic patient, what happens is prolonged hyperglycemia is there, which is not treated. So the patient is exposed to high blood glucose levels. And then the hemoglobin is exposed to the high glucose levels. So this glucose will get attached to the uh, valine amino acid. Okay, valine amino acid, which is present as a terminal amino acid in beta chain of the hemoglobin, globin part of the hemoglobin. Okay, so when it is attached like that, then we call it a glycosylated hemoglobin. So only when this exposure is for a long time, more than 3 months, this change in the hemoglobin will occur. So that means if the hemoglobin was exposed to prolonged hyperglycemia, that means the poor glycemic control was there for a long time, at least a period of 3 months or a period of 12 weeks, what we say. So, especially if this level is above 10%, what we take normally is as anything above 6.5 percent is abnormal. Uh, so, if you see this high levels of glycosylated hemoglobin in the second trimester, what does it mean? That means the whole of first trimester there was continuous hyperglycemia. That means there is a chance for more malformations. The risk for malformations is quite high. So basically, glycosylated hemoglobin represents the glycemic control in the previous 3 months. Okay. So to manage the patient to know about the control, we usually do this HbA1c. Right. So how do we manage these patients? Management, it needs a team approach involving an endocrinologist, a physician, a perinatologist, obstetrician, See, so many people, because the mother has to be managed, after birth, the baby has to be managed. So, and the patient should be educated to know the nature of the disease. So, I've already mentioned the preconceptional. If she's a diabetic patient, pre-gestational diabetes, that means she was diabetic even before pregnancy. Before she conceives, before she becomes pregnant only, you must give counseling to the patient. Okay, so how do you manage? First line of management is the diet. Now, diet control. If it is mild hyperglycemia, many of the patients may not need any hypoglycemic agents or insulin. Only simple diet control will um, control the hyperglycemia. Basically, calorie consumption should be 2000 to 4000 kilocalories per day, or 38 kilocalories per kg weight, or 300 kilocalories above the basic requirement. Okay. Yes, and this should comprise about the food should comprise of 50 to 60% of carbohydrates, 12 to 20% of proteins, and 10% of fats, uh, 10% of saturated fat, and 10% of polyunsaturated fats, and the rest is monounsaturated fats. Okay, then avoid sugar, restrict cholesterol. So, this is the composition of the food and the calorie requirement. Basically, this food is given as 3 meals, 3 snacks. Even for the non-pregnant patients, generally what the endocrinologists tell you is 3 meals, 3 snacks. That means there should not be any prolonged periods of fasting in between meals. Okay, not just taking 2 meals or 3 meals per day. She must eat more frequently but less in amount. Okay, so that the the person's pancreas is challenged with smaller amount of food but more frequently, and whatever the insulin that is being produced by the pancreas should be enough for the reducing the blood sugar. Okay, that is the whole idea of these frequent meals but less amount of calories. Okay, uh, and if she's overweight or obese, calorie restriction should be more. She must take even less calories. Okay. Then, apart from the diet control, exercise is very, very important. For a pregnant woman, also, exercise should be there. With exercise means we don't tell her to do all gymnastics or jogging or anything, but brisk walking is the best form of exercise for the pregnant woman. Walking for 30 to 45 minutes every day is goes a long way in controlling the blood sugar. Then the role of insulin. See, most of the pregnant women we give insulin. Oral hypoglycemic agents are previously we never used to use these oral hypoglycemic agents because most of these agents pass through the placenta into the fetus and they accumulate in the fetus, and after birth you cannot remove the drug that is present in the fetus, isn't it? So prolonged hypoglycemia in the fetus was a possibility, and also in the mother also the glycemic control was not good, not adequate with oral hypoglycemic agents. So most of the time we convert these patients into insulin. Suppose a diabetic patient has become pregnant, pre-gestational diabetes. As soon as she becomes pregnant, you can switch her over to the insulin. Or so, what are the indications? Practically, though indications I'm giving a list, practically all most of the pregnant women we put them on insulin. So, any pre-gestational diabetes patients or gestational diabetes with high hyperglycemia, not getting control with only food and exercise, then, or if she had a pre-gestational or gestational diabetes in previous pregnancy and it was not controlled with insulin. Okay, right, then you have tried oral hypoglycemic agents but the control is not good, poor glycemic control. So all this may are indications for insulin, but practically as I told you, most of the patients we put them on insulin. Now, so this insulin, what is the insulin that we give? Most of the time, we cannot give very long-acting insulin because the control of the insulin, hyperglycemia is not good with them. So what, and very rapid-acting insulin also we can give, but the problem is more number of injections have to be given, 3 or 4 injections have to be given per day. That is before breakfast, before lunch, and before dinner. So usually what we do is a combination of short acting and intermediate acting insulin. Okay, various trade names are there like mixed and all. Short combination of short acting and intermediate acting in the proportion of um, 30 to 70, in the ratio of 30 to 70. Okay, so 30 of short acting and 70 of intermediate acting. Now, with this, we give 2 times a day, before breakfast and before dinner. Before giving the insulin, we always do a, with a glucometer, we do a blood glucose estimation. Now, see, every pregnant woman who's diabetic should be taught how to use a glucometer so that she can estimate her blood glucose herself. It's very simple, just a prick on the finger, and strips are there. With the help of that, she can find the blood sugars. And according to that, we can, change the amount of insulin that we are giving. That's why I'm not telling you a fixed dose or anything. Right. Then what is the role of oral hypoglycemic agents? As I told you before, previously we were not using, but now there are two agents which are being increasingly used in pregnancy. That is glyburide, or it's also called glibenclamide. You must have heard, you must have learned in general medicine, glyburide or and metformin. Glyburide given as 2.5 milligrams to 20 milligrams per day, as the patient needs, see, depending upon the control of the blood glucose. So dose varying from 2.5 milligrams to 20 milligrams per day. And metformin is another drug. Metformin 500 to 2000 milligrams per day, depending on, again, on the requirement. It has been seen that reasonably good control is achieved with these two drugs. And many times both insulin and metformin also have been used in the same patient for optimization of glycemic control. Okay. Uh, okay, what else we do for the pregnant woman? In investigations, I didn't mention forgot to mention the ultrasonogram. Ultrasonogram in a diabetic woman is very, very important because you can make out so many conditions, particularly to know about congenital malformations in the first trimester. Very important. Then later, growth of the baby, any macrosomia. See, excessive growth of the baby, we call it macrosomia. So fetal macrosomia detection, very, 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 very important. Right. Then during pregnancy, you also look for preeclampsia also, as I told you, increased incidence is there, because then your management of the case becomes different. So now, what are diabetic complications that can occur in pregnancy? That is, particularly if the woman, if a diabetic woman has become pregnant, that is, she has got a pre-gestational diabetes. Nephropathy is a possibility. Uh, and if nephropathy is there, very high nephropathy, patient is in renal failure, high serum creatinine, pregnancy is a contraindication. If retinopathy, benign retinopathy, she can become pregnant. But if it is proliferative retinopathy, rapid progression will be there, which may lead to blindness. But nowadays we have got treatment with a laser and all that. So even proliferative retinopathy is not a contraindication now. Coronary artery disease, if the patient has had a previous heart attack, then absolutely it is pregnancy is contraindicated. Then if ketoacidosis is there, ketoacidosis occurs, you have to be on the lookout for ketoacidosis, particularly if it is a pre-gestational diabetes, type 1 diabetes. If the patient gets an infection, or if she's got hyperemesis or any acute conditions, stressful conditions, she can become hyperglycemic, and then ketoacidosis can develop. So you have to be lookout for all these conditions. So then, how do you manage the obstetric management? That means pregnancy itself. So far, I have told you how to manage diabetes in the pregnant woman, how to reduce the blood sugar. Now, how to manage the pregnancy itself? How to manage the obstetric part of it? What are your goals? Your goal is to prevent congenital malformations by good glycemic control in the first trimester. Yes, then to prevent sudden intrauterine death of the fetus, close maternal and fetal surveillance. Then, at the same time, you do not deliver the baby too early and cause prematurity and respiratory distress syndrome in the baby. Okay, and you have to decide how you are going to deliver the baby, route of delivery, whether vaginal delivery or cesarean section, and you have to decide when you are going to deliver. You going to wait till term, or you are going to deliver before the patient reaches term. So all this comes under the obstetric management. Now, maternal surveillance, all this I've already told you. I'll quickly go through again. Preconceptional counseling you have to give. Then you evaluate for malformations. HbA1c levels you must do. At particular at 10 to 12 weeks, it tells you about the glycemic control during the previous 3 months and whether the chance for malformations is there or not. Do an ultrasonogram. You can do a maternal serum alpha fetoprotein to detect any neural tube defects. Antenatal visits should be more frequent, at least fortnightly. See, what we usually say up to 28 weeks every month, isn't it? No, this has to be more, at least every 2 weeks, and then every week till she delivers. And at each visit, what do? You see how much weight she has gained, see for the growth of the fetus, fetal condition, then any evidence of preeclampsia, any evidence of polyhydramnios. Every visit, you do a fasting sugar and post lunch blood sugar and HbA1c. All this must be done at every visit. Right. Then fetal surveillance, the usual fetal surveillance tests. These are the common tests for every pregnant woman. I think a class was taken on fetal surveillance, antepartum fetal surveillance for your ultrasonogram for biophysical profile. You can detect congenital malformations, macrosomia, and fetal well-being by biophysical profile. Fetal kick count, which mother counts at least 10 to 12 movements in a matter of 12 hours. Okay, it is a safe and non-invasive, non-stress test. Is a that I have already told you in previous classes, where by the help of a CTG machine, when the fetus moves, the heart rate increases. That we detect by recording the fetal heart rate on a graph paper. Right. Then amniocentesis, not commonly done, occasionally to know if any alpha fetoprotein is raised, but now very good ultrasonogram sonologist can detect most of the malformations. So this we are doing less and less. And at term, to know about the fetal lung maturity, occasionally, as I told you, the surfactant level is less in these patients, in these babies, compared to the normal babies. So even at 38 weeks, 39 weeks, the fetal surfactant level may be less. So to know about the actual lung maturity, what we do is a LS ratio, lecithin sphingomyelin ratio in the amniotic fluid, or the presence of phosphatidylglycerol in the amniotic fluid. So LS ratio 2.5 to 3, or if phosphatidylglycerol is present in the amniotic fluid, it means the fetal lungs are mature and you can deliver the baby. So that is only indication. That also we don't do in every patient, only when we are doubtful about the fetal, about the gestational age, and there is a confusion about it. Right. Then during the delivery. Okay, before delivery, when will you deliver and how will you deliver? See, the diabetes is not a compulsory indication for cesarean section. Normal delivery can be allowed if there is no fetal macrosomia, good pelvis is there, no other associated complications are there, patient under good euglycemic control, then a vaginal delivery can be allowed. If any complication is there, or a large baby is there, or a CPD is there, any other obstetric indications is there, like a breech presentation or a transverse, like any other indication is there, then you go for a cesarean section. Right. Then time of delivery. When will you deliver? See, the time of delivery, you decide by so many other things. Any presence of any maternal complications, or fetal surveillance shows that there is fetal distress, or there is a risk of IUFDs. Say previous history, she had a previous intrauterine fetal death, and then you would not like to go, stretch this pregnancy beyond the gestational age at which the previous fetal death has had occurred, isn't it? So you would like to deliver before that gestational age, or the fetal lung maturity. Then, or if the metabolic control, that glycemic control is good, or it is becoming worse, and so you have to deliver the baby. So all this will decide the time. If there are no complications, you can deliver at 39 to 40 weeks. But if complications are there, then you deliver by 38 weeks. And route of delivery, I have already told you. If fetal weight is less than 4 kg, vertex presentation, pelvis is good, no fetal distress, no other associated complications, yes, vaginal delivery you can allow. Now, suppose you are allowing vaginal delivery, you can induce labor. You can induce labor by amniotomy or oxytocin. If cervix is not favorable, prostaglandins can be used. And how do you induce? Overnight fasting is there. Morning, you withhold the dose of insulin. Okay, because you're not allowing the patient to eat anything. You give her a continuous drip infusion of 5% dextrose saline, and frequent blood glucose estimation should be done. Don't allow the blood glucose to go beyond 140 milligrams per 100 ml. If it goes beyond 140 milligrams per 100 ml, then you can add insulin to the drip itself. To the insulin drip itself, you add the insulin. Now, uh, yes, then you allow the labor to progress. And the rest of the management of labor is like any other patient. When the cervix is fully dilated, if necessary, forceps can be applied, or uh, vacuum can be applied for the delivery. And be on the lookout for shoulder dystocia. As I told you, diabetic babies are prone for shoulder dystocia, so you be on the lookout for that. You be alert. And after delivery, be on the lookout for any postpartum hemorrhage. Prevent postpartum hemorrhage. Okay, in the um, in the puerperium, after delivery, one thing you must remember is insulin requirement declines immediately after delivery. The mother will not require the same amount of insulin that she was given before delivery. So after delivery, uh, say on the same day or the next day, the blood glucose estimation should be done, and you have to modify your insulin accordingly. Okay, less amount of insulin will be necessary. Okay, sometimes blood sugar will be normal, she may not even require any insulin. That means that what she had problem was only a gestational diabetes. Gestational diabetes is it's subsides after delivery. Okay, so and this patient after discharge also you have to ask the patient to come back at 6 to 8 weeks and do blood glucose monitoring. When hyperinsulinemia is still persisting, what does it mean? That means she's already got diabetes. Either she was a pre-gestational diabetes, or she developed, this was a gestational diabetes, but she became diabetic. See, 50% of these patients with gestational diabetes are likely to develop diabetes mellitus in later life. You must remember that. Another thing you must remember is 1 to 2% of the babies born to a diabetic mother are likely to develop diabetes when they become adults. These two things you must remember. That is why diabetes is extremely important. Okay, I think it's past 11 o'clock now. I will end my lecture.